So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get paid.
Welcome to another episode of Farm So Hard. We've been waiting this for a long time. I can't believe we waited 10 episodes later to do it with my counterpart, Jimmy Pruitt. Jimmy, go ahead. Welcome and introduce yourself.
Yeah, for you guys who don't know me, I'm the other end of the Farm So Hard podcast, Jim Pruitt, aka PharmD in the ED, and super excited to have this combined episode where we look at something from an admin perspective and then go ahead and transition it downstairs to the ED where everyone tries to be a boss with a whole lot of sauce.
That's right. All right, so today we're going to be talking about early ED discharge for deep vein thrombosis. So some quick definitions before Jimmy hits you guys with the pathophys as a nice refresher for our pharmacists out there. We're going to say some common terms. We'll say SCAMP. What a SCAMP is a standardized clinical assessment and management plan. Essentially what it is, they're just financial clinical initiatives that can help benefit not only the hospital, but for patients. DVT is a blood clot in a deep vein, usually in the legs. And PE, which is a pulmonary embolism, a condition in which one or more arteries and lungs become blocked by a blood clot. So diving a little deeper than that, Jimmy, can you hit him with the pathophys for DBT, VTE, all that jazz?
All right, guys, it's going to be a lot more than you guys are used to me kind of get into. Major theory delineating the pathogenesis of a VTE or venous thromboembolism. And what that's really going to come down to, you're going to have a few things happening. You're going to have alterations in blood flow, venous stasis. The blood's going to be pooling and hanging out in one area. Then add on to that the fact that you can have vascular endothelial injury. Endothelium is sitting there hanging out, having a good time. It says something damages it and release an entire host of cytokines and inflammatory markers that's going to generate the perfect environment for a clot to be produced. And then lastly, you're going to have alterations in the constituents of the blood. So again, what all those things that can be released from the endothelium, all that's going to come together. So what you're going to have, you're going to have alterations in the constituents of the blood, whether that's going to be something that's inherited or acquired, and produce this hypercoagulable state. And that's going to lead to the perfect scenario where you have a composition of a clot.
So background, and I love how we're doing this from a clinical and administrative perspective. In 2003 to 2014, inpatient hospital costs range from $3,000 to $5,000 per admission for a primary DVT diagnosis. The average length of stay days for a DVT can range from 4.9 to 7 days. Recurrent VTEs that requires readmission could be up to 48% more costly than the initial event. And what I like about that last bullet is that a lot of that is making sure that patients go home with the drug. There is appropriate patient follow-up, so you can kind of see how, from a transition of cares proponent, like how important that is. What is important is like, why are we even talking about this today? So there is some decent data out there, like protocols for outpatient DVT management found a cost reduction of over $2,000 per patient with enoxaparin. 36% of patients have expressed the inability to afford medications. And Burnett had a study that discusses that DOAC patient selection criteria for DOAC use included adherence, patient follow-up, and confirmed availability to obtain a DOAC. And I'm pretty sure Jimmy has interacted with those patients in the ED where he's like, I don't know if this patient can be adherent. I don't know if we're going to see this guy again. And I don't even know he can even afford the drug.
Absolutely.
Further on, Jimmy, what else do you think is important and relevant about this topic?
I think for a lot of the PharmDs that are going to be down at ED, you're going to have a discussion with your providers and say, hey, what's your dispo for this patient? And they're going to go based off what they assess that the patient be high risk or low risk. And you have to know what are your options. And then once you have the option to send a patient home, you may get a consult. One of my shops, we have a consult that comes out the pharmacy, and you're responsible for counseling that patient and assuring that they can get those medications and setting them up for an outpatient follow-up. So this is something that a lot of you guys are probably already doing, and you being involved in this, and this is going to be something that's part of your day-to-day activities.
Yeah, absolutely. And then further on, like supporting like more of these kind of initiatives that Jimmy was talking about, Falconieri and colleagues, they found that none of the 106 patients that developed the VTE recurrence on outpatient therapy, and they did not even experience any clinically significant bleeding. Pharmacist management of DBT program in the ED had a 91% initial clinic follow-up. So another role for like pharmacy right there, just kind of leading the charge on that. And then starter packs. So there is one for Eliquis and Xarelto that when given at discharge, they can increase proper dose transition and overall adherence. There is a study out there with Rivaroxaban starter packs that has shown this kind of transition. So again, like we like to practice not only evidence-based admin, but also evidence-based pharmacy practice, right, Jimmy?
Absolutely.
So the first study that I'll quickly go through is a pharmacist-led DVT treatment program. So in summary, a patient comes in the ED, pharmacist education takes place, they schedule an outpatient follow-up. In this study, they had a warfarin clinic. 30 patients stayed within the program. There was one recurrent DVT and one recurrent bleeding event. But overall, those 91% attendance. Limitations, again, 30 patients, small sample size. And at this point, there was no DOACs used in the study. Just some things I wanted to add was that follow-up is important. Making sure you have the appropriate exclusion-inclusion criteria. And this is like the first study that proved that early ED discharge for non-complicated DVTs is actually possible. Jamie, did you have anything on that study you wanted to share?
I think it's important to kind of, from a historic standpoint, to figure out where we came from, especially these patients that are on warfarin, and realize that we've been sending patients home on this as well. So
the second study is Castelli's article, and here they dispensed the Rivaroxaban starter packs. So these are patients that were discharged, and it had a comparator group of patients that received the starter pack versus ones that didn't. They kind of had to go retrieve their own medications. And then they had a follow-up at 21 days, and they found no difference in transition and good adherence and comprehension. So it kind of shows that regardless of the patients getting them themselves versus patients receiving the starter pack, they were able, starter pack showing like it has helped patients transition into appropriate therapy. Other limitation in the study, that there was only 29 people in the study, and they didn't use the official commercially available pack. This was like a customized pack where like the outpatient pharmacy prepared for these patients. So this is kind of interesting that if you're a hospital or ED where you have the retail pharmacy on campus, like that's just an extra service your outpatient or retail pharmacy can have. Some comments I want to add was that it did include not only DVT, but also patients with PEs, which I thought was interesting. They're sending patients home with non-complicated PEs. 22 days was too long of a follow-up. There may be some CMS requirements where they should follow up in 3 days, week, etc. So you have to look at that. They did use a PESI score that they use to indicate low mortality risk for patients in PEs, and then significance of education and increased adherence compared to other trials that discussed early direct ED discharge.
Yeah, and I like this study because it did a few things for me compared to some of the previous ones. This is something that, a lot of ED pharmacies are actually looking at right now. I think 22 days is a long follow-up, but based off what I've been seeing over the past, that's probably a realistic follow-up. And more from the administrative side what should be and from a compliance standpoint. But when I'm scheduling these appointments, that's about the time that I'm actually getting these patients in because we're just so stacked up. And I like the fact that they use some objective, score to identify those low-risk patients to kind of help us out and make us all feel very comfortable about sending these patients home. So I really like this study here.
I agree. Like the PESI score is interesting, help with PEs for sure. The last article we're going to review is a Choose article, and where they also use a starter pack. This was a retrospective study where patients were discharged from the ED, and compared to the patients that were sent starter packs versus ones that weren't, that was a 7% versus 18% of those patients were readmitted. Other limitations, 4 patients were unable to obtain the drug. 29% of patients were actually lost that follow-up. Some comments I had on this study was that better sample size, 41 versus 34 patients, recognized the question of ability to retrieve the med. So this article kind of discusses of like, it's great that you can have all these early directed initiatives, but a patient can't go home with a drug. It kind of defeats the purpose. And then the one thing I didn't like was that there was no cost analysis completed, just because like from a administrative perspective kind of shows like the value about that, like because we know how expensive these drugs can be. And like previously mentioned in our background, discussion was that, not only adherence, but can patients actually afford the medications? Any nuggets on this trial, Jimmy?
I think it's very similar. I would have loved to have some of those verified or validated tests to kind of identify patients and talk about that. And I think just identifying where these medications are coming from and that hours of operation for these will be a key thing to kind of know as well.
And again, this study did look at these patients were diagnosed with DVTs and PEs. So what we're going to talk about today, so this was my PGY2 admin project we got going. So I just kind of wanted to share things that we were doing at my hospital, and I'm sure Jimmy could chime in there. So what we kind of did was that we just want to keep it simple, very non-complicated distal DVTs, just because we want to make sure we got ED provider buy-in. So patient had to be an adult patient. They had to be extremely low risk. What do you mean by low risk? Couldn't be obese, couldn't have a previous VTE, couldn't have active cancer, couldn't be on any oral contraceptives or hormone replacement therapy. And then had to make sure you had to rule out whether or not if they came in for chest pain, you had to rule out for PE or MI. And if they did, then we immediately took those patients out of the algorithm. But the next thing we did for those patients is, all right, they're 18 years old. So far, their risk factors look good. We're going to do the Wells criteria. If they had a Wells criteria score of greater than 1, then we went ahead and went further down our treatment algorithm, whether or not these patients were a candidate for a DOAC starter pack. Jimmy, can you dive in a little further about Wells criteria?
I think from that standpoint, everyone here, I think at this point in their career, we can go through and talk about whether a patient has active cancer, calf swelling, pit edema, different things like that. But you have to go online or go on get one of these apps called MD Calc, or that's the one that I use. But another calculator, Clinic Calc, you can get that as well. And when you're assessing these patients at the bedside, you can just go ahead and run your Wells score from that standpoint. We notice it's a validated test that we can use, and it literally takes me, less than 10 seconds to calculate a score and provide it to my provider versus going through each and every step and try to identify yourself. So definitely I would encourage a lot of our active providers and a lot of the pharmacies who kind of went through the academic component of it, just download one of these apps, calculate it, and then identify how you can use the Wells score versus sitting there going back and forth about each component that's in at this point in your career.
Yeah. And what the Wells criteria score does, it kind of rules in DVT. So if they had a score of 1 or greater, then in fact it is likely that they do have some kind of DVT or VTE event. Some examples of the thing the Wells criteria looks at active cancer, calf swelling, pit edema. And again, a score of 1 and 2 is considered moderate risk, and the patient should proceed to high sensitivity D-dimer testing. So again, it's not to replace ultrasounds, right? It's just to kind of if you can quickly rule this patient out, then that means that they definitely don't have a DVT. So, all right, great. Patient has a Wells score of 1 or greater. They definitely don't have an MI or PE. So now we're thinking a DVT is indicated. Is this patient eligible for outpatient management? So, for example, do they have anything else going on? For instance, are they having a stroke, or is it hyperglycemia? If it's only just for if the primary indication is a non-complicated DVT, then sure, then they may be eligible for outpatient management. We do have some criteria for that in our algorithm, where the patient had to be ambulatory and in a stable condition, they had to be able to move around, normal vital signs, no significant symptoms of DVT, low bleeding risk, no severe renal insufficiency, able to comply with prescribed anticoagulation, and agree to follow up. And again, no other clinical indications for admission. And then the other thing they had to look at was whether it was acute or chronic DVT. So this DVT, the same location, same blood clot from the previous ED visit. If it was chronic, then the patient wouldn't meet our criteria. If this was an acute event, then we'll go ahead and provide them with a DOAC starter pack to send home. In our institution, we use Xarelto. And in the Xarelto starter pack, we'll talk more about the Xarelto starter pack, but then at that point, going down the algorithm, that's how a patient met criteria. So in summary, 18 years and older, had to be low risk, had to rule out MI or PE, had to have a Wells score of 1 or greater, had to be confirmed by ultrasound, and had to be eligible for outpatient management, and to make sure that this was in fact an acute event. Then therefore, we sent them home with a 30-day starter pack.
Yeah, I think it's pretty key that you outline a lot of these things, because a lot of times from our perspective downstairs is you can ask about, hey, is this person sick? I think once for some reason the ED gets so simple that you ask them, hey, is this patient sick? Like, how do you feel about them? Does this patient worry you? And then also a key thing that you mentioned was whether this was an acute or chronic DVT, because I've been consulted multiple times for a chronic DVT that's been somewhere and they want to send them home on a starter pack because, they just wasn't taking it before, or, something else happened. And, we have a very, indigenous population at my second shop, and someone stole their medications because they didn't have access to proper home, and then they want to restart them on these packs. And I think if I came to you as an admin and said, I gave this patient with a chronic DVT a starter pack 3 or 4 times, I don't think you'd be too happy with me, and my numbers will look pretty bad.
Yeah, absolutely. So this initiative was great when the algorithm came to our desk, but then we're like, how are we actually going to dispense these to the patient? So a little more background. So we had to choose between Eliquis and Xarelto, and the only reason why we felt we had to select one was just because the dosing was different, and we just wanted to keep things simple. If the ED provider had other preference, they're more than welcome to hand the patient a prescription instead of giving a starter pack. We're totally fine with that. We just went with Xarelto mainly because of a safety concern, because in the starter pack there was 51 pills, and Eliquis there's 84, and we really feel comfortable just sending a patient home with 84 pills. So that was mainly why we just went with we're just going to stick with Xarelto. So how are we going to dispense this? So patient confirmed DVT and met inclusion criteria. For us, we made sure that the provider had to enter our order set, and the pharmacist had to verify the protocol, kind of double checking that in fact patient met criteria. We dispense these out of our central pharmacy, and there was a labeling process that took place. In other words, if we're going to send patients home with drug for outpatient use, so if you're going to send something with a patient home that has more than a 3-day supply, it has to be a multi-dose medicinal drug, which means that it has to be a commercially available product like inhalers, products, insulin vials. So in this situation, the DOAC starter pack. So if you pre-packed anything that was more than 3 days, that would technically in the state of Florida be illegal, because it would meet outside of our limited community permit. So outside of that, we'll dispense out of our central pharmacy, make sure our labeling requirement met the standards of the limited community permit that we had in the state of Florida. Then the nurse would administer the first dose from the starting pack, which kind of meant patient received dose in the hospital, so they could be sent home with it. And then they kind of document that, yes, the patient received the pack and they're sent home, just to kind of help close the loop. The last part, which I felt is the most important part, was that the care navigation team that we have here and the transition of care pharmacy team actually followed up with the patient, made sure that they followed up with the provider, and if they need to meet the pharmacist in the clinic, they're more than welcome to, if they had to switch to a different DOAC for insurance purposes, so they can continue therapy if therapy was warranted for longer than a month. Further education, because again, these patients come in the ED and they come thoroughly confused. A lot's going on. The information is just thrown at them, so it's an opportunity for the pharmacist to kind of slow things down for them and help them out. So, Jimmy, any questions about the workflow here?
So there's a few things I want to kind of highlight here. The first part is going to be making sure that system that identifies the ED pharmacist that these patients are, there. Do you have a consult? Do you have, is someone calling you? Is there a certain way to identify these patients that's different from all the other patients that you have in your ER? So again, if you have a consult or some type of patient care tool that helps you identify these patients, I think that's going to be key. Being where I've used Epic and Cerner, the two more popular EMRs, there's a particular way to identify these patients. So that's going to be one thing. The next thing I have to say is obtaining this drug from central pharmacy. Is this going to be something that's sat? Is this something that we can have sent down pretty quickly? Do you have a runner, or can this be sent to the tube station? So identifying what's the quickest way to get these patients this drug and get them counseled is going to be another thing. And making sure that the RN is actually documenting this on the MAR, because I can see where there's become some issues where we're giving them this medication and we're giving them one dose, but is there an inpatient order for that one time before they're sent home? And lastly, making sure we have somewhere to document these things that we did, and making sure there's adequate handoff to the transition of care team to make sure that they have all the resources they need to continue this care. So those are my big things from an ED pharmacist perspective, is identifying those patients, identifying going to find methods to get the drug very quickly and making sure everything's documented on a MAR and making sure at some way, whether you're using something like Theradog, Vigilance, or whatever your tool is to communicate amongst pharmacists, that's done. Whatever you did in ED has been documented.
Again, like, so what is a limited community permit? And in every state, it could be different. But for those of my Florida folks, patients at the hospital who are under continuation of a course of therapy, it cannot exceed a 3-day supply. Patient or caregiver, education and administration of the multi-dose medicinal drug, if necessary on individual basis. Multi-dose medicinal drug as used in this rule means, but is not limited to, commercially available multi-dose packages, such as inhalers, ocular products, insulin vials, pens, otic products, bulk antibiotic suspensions, topical agents, Medrol dose packs, etc. And provided that ink containers may exceed a 3-day supply. So if it's as long as it's commercially available and it's more than 3 days, it's fine. Just as long as they're able to break into it. So yeah, a lot of people ask me like, all right, it's great you're doing this initiative. What have you guys learned? I'm like, all right. Well, at 8 weeks, we avoided 26 admissions and a cost avoidance of over $63,000. And this is only at 8 weeks. And this only took place at 3 of our EDs, and it was only for non-complicated DVTs. So you can kind of see that from the C-suite or from a SCAMP standpoint, like where they see the value of this. And none of these patients have been readmitted for a DVT. Any of the numbers there, Jimmy, I have for you jump out at you?
I'm looking at this from an ED FTE perspective. With everyone trying to get the 24/7 coverage, I would love to see what happened if I can apply this and collect a ton of patients. And if I can save you close to $500,000, and I can justify just getting one more pharmacist or 1 or 2 more with that, in the system, that'd be great for me. And I think it is from a standpoint from you. If I provided you these numbers and said, hey, if this project that I set up, if we can do this throughout a system, we can save yourself close to $2.5 million. I think you'll be pretty happy with me and be able to provide me with the extra FTEs to make my ED 24/7.
And like I said, like one of the most important pieces of this project was the transition to care team. So I have those numbers for you. But the first thing I want to share was like, what is the median? What was the turnaround time for the patient in the ED? The median time for that was around 4 hours and 41 minutes. So from everything after being diagnosed, all the tests, like they're able to go home with the drug within 4 hours, right? So now you have beds, you have availability ED. Pretty sure the ED managers would love that.
Absolutely.
The transition of care team was able to capture 15 of the 26 patients and aided 6 patients with payment assistance for continuation of DOAC beyond 1 month. So like they're able to help out 6 of the 29 patients. They did note that there were 5 drug-to-drug interactions for those patients, and 8 patients have received extensive medication education assistance. What they meant by extensive medication was that it kind of took a little more than 30 minutes with the patient. The drug-drug interactions that they found were mainly patients who were taking NSAIDs, and the patients who received extensive medication education also received education on duration of therapy, how to take the medication, and knowing when to contact the provider. So those are the key things that we found on the transition to care side. So said a bunch today, like essentially trying to help you guys out, like how to start this kind of initiative in your ED, just summarizing everything. So in my study, or what we learned here in my health system, was that early direct DVT with rivaroxaban starter packs have proven to reduce admissions at 8 weeks. This research demonstrates how hospitals can be compliant with regulatory standards, pharmacy services, and serve the community by providing no additional out-of-pocket costs for the packs. And that was the other thing too, I forgot to mention about this initiative, that we gave the drug away for free. That we felt that it was great, like for our patients that we were giving the drug away for free. But we felt that by giving you the drug, it's actually cheaper than admitting you. So therefore, like it was cost neutral, if anything. So it was pretty nice that we were able to give the drug away for free to these patients. And then the last one I highlight, considering like a projection of 900 admissions for our health system with uncomplicated DVTs annually, we'll have a projected cost savings of over $2.5 million. So that's right there, like the money slide, right?
Absolutely. So
far, like one of the other questions I get, like, all right, so what are the barriers or limitations for these kind of initiatives? One, is it legal in your state? Is there a limited community permit? I'm only familiar with Florida, so I apologize for other states that may have questions. I know, like, I saw on the ASHB blogs, like people in North Carolina were trying to get this going. Levels of automation. So the common question I got was like, hey, can we put this in a Pyxis machine or Omnicell? If it's dispensed out of there, you have to be able to track the lot number. If your ADC can track in fact, which lot number the patient received electronically. That would be beneficial just because of, in case of a recall, you would need to be able to reach out to that patient. On our end, we didn't have that functionality, so therefore we had to manually write in the lot number and everything that the patients received. So that is like a limitation for the central pharmacy, just because of it was a process that we had to own and not nursing, just because we had to document the manufacturer, lot information, and the expiration date, just so that we'd have to track these patients in case of recalls. And then the accuracy of documentation for Wells criteria. Not Wells criteria specifically, but the characteristics of the Wells criteria, like items they're using for the scoring. A lot of times, Jimmy, like ED provider notes are pretty short and sweet, maybe missing some information. So that's the other thing. So if you're looking at those patients like HAS-BLED score, those kind of things, like it may not have all the required information that you need to know. So those are like some items, like when you're working with your providers, like, hey, does this patient, like if they didn't mention anything about active cancer, like, hey, do we know in fact this patient has a history of cancer? Like that's something like you would want to know or be able to look up. So those are like some of the limitations. I don't know if there are any other limitations that you've seen, Jimmy, about these kind of initiatives.
I think just making sure your ED providers are actually educated on what this is going to mean. I think a lot of times they've been thrown a ton of different information, and depending on if you're at an academic site, you have to include residents in this education as well. So I think that the sites that this was done at maybe didn't have as many. I know one site in particular has the ED residents there, but across the system, what was the kind of the breakdown of those patients that were sent from an academic center versus the more community sites, and that drive your numbers. Also, again, the automation was a huge thing for you, as you mentioned. One of my shops has Omnicell, another one of my shop has Pyxis, and figuring out which one can be used to have that lot number identified and to make this a little easier. So I think those things would be key, and the accuracy of documenting the Wells criteria is I can see that being something that is a battle that you're going to lose, especially within the ED. And these patients are, for a good reason, those are not very sick. And the last thing I want to mention was the fact that patients that had these small or low risk PEs, that could be another group of people that we can identify that maybe can benefit from this and provide an even higher number of patients that can be discharged from the ED and increase the revenue that can be generated from this. So I think those are the key things, just figuring out how can we do it, the education, and does the type of facility that you're at drives whether you can or cannot do this successfully, and the accuracy of documentation, that may be a losing battle.
All right, well, Jimmy, I'm very glad we got to do this together. I don't know why I waited so long.
It's a pleasure. We're sitting back just waiting for the perfect timing of it. Yeah. So again, thank you guys for listening. Oscar, thank you for having me as like a guest on the show, from your perspective looking at things. And it's just been pretty cool to kind of see this. And this is something I'm going to bring back to my C-suite. Like, hey, I have this idea. I don't know where I got it from. They saved the hospital, $2 million. Are you interested in listening?
So again, guys, I'm Dr. Oscar Santalo. I'm one of the pharmacy operations and compliance coordinators at Advent Health Orlando. And I'm here, one of my best friends, previous co-resident,
JP, aka PharmD in the ED. But no, I'm Jimmy Pruitt, pharmacy clinical specialist in the emergency department.
Yeah. Where can they follow you on Twitter, Jimmy?
Again, if you don't know, you should know. Pharmacy at PharmD _ in the ED.
Yep, and you guys can follow me on Twitter at PharmSoHard _OS, and then you also hit me up on LinkedIn. And again, see you guys till next time. Thank you, Jimmy. Thank you, guys.
Thank you, Oscar.